Welcome to the first episode of Season 4 of the Leukopak Lady. I'm so glad you've joined me. Thank you to my faithful viewers and greetings to anyone who just found me. I hope you enjoy my perspective on cellular starting material, specifically leukopaks. I bring to this series my near decade-long experience in the field and expertise from helping many collection centers and cell therapy developers with donor and starting material strategy. In this season, I'm going to talk about something that often gets ignored early in cell therapy development, starting material as part of the evidence package that supports the investigational new drug or IND process. This is where your starting material strategy is leading. In this season, I'll examine closely what about the starting material is essential to the IND application. And as a reminder, I almost exclusively focus in this series on allogeneic cell therapies and the healthy donor cellular starting material that feeds into the manufacturing of those therapies. In allo cell therapy, the story doesn't begin when cells enter the manufacturing suite. What happens before that is just as important. I call that the first mile. Who's the donor? Are they eligible and suitable for the collection? And are they qualified for the specific manufacturing process being performed on their cells? How is the collection performed and controlled? What is the composition of the collected product? Is the material shipped fresh or cryopreserved? How is everything tracked and documented? How is quality managed? I won't repeat what I've already talked about in this series, but I will discuss these essential first mile program attributes in the context of the IND. An IND application is the submission a therapy developer sends to the FDA to request permission to test an investigational therapy. It's a package of evidence that shows the FDA that the proposed therapy is reasonably safe to begin clinical testing and that the product, manufacturing process, testing strategy, and clinical plan are understood well enough for first-in-human study. What goes into the start of manufacturing is an essential part of the story that developers tell about process understanding, control, and risk. As programs move from the research phase and toward their IND, they need to demonstrate that they have control over the first mile, even when someone else is responsible for it. These operational details are an essential part of CMC. CMC, or Chemistry, Manufacturing, and Controls, is the section of the IND that explains what the product is, how it's made, how it's tested, and how quality is controlled. Part of CMC is demonstrating knowledge of the makeup of key materials involved in the manufacturing of the therapy, particularly those that affect product quality and efficacy. This especially includes the living cells that are the backbone of the therapy. Starting material assumptions have a way of getting embedded into the process before anyone realizes they've become assumptions. These carry over from research phases of development. For example, a process may work well in a small number of donors. However, the development team may not actually understand how the process will perform in a different set of donors. This can become a gap in CMC. The same issue applies to collection. If early development work uses fresh leukopaks from one collection site, manufacturing variability may suddenly appear when the team expands their collection partners to additional sites or starts using cryopreserved material. This can become a gap in CMC. Before the IND is submitted, the team should be able to explain known sources of variability, what they've done to understand them, and how they plan to monitor and control them as development moves forward. Knowing the donors and starting material on a deep level closes those gaps in CMC for these living therapies. Please join me for the next episode. I'll define IND-enabling first-mile data and how to separate interesting information from data that truly supports the IND. See you then.